So let's talk about systolic pressure versus pulse pressure variation. So if you were to have an apneic baseline at the end of a long expiratory pause, this is your A-line tracing essentially. This is your systolic pressure, this is your diastolic pressure, this is your dicrotic notch. So the systolic pressure at the end of an expiratory pause becomes your baseline, and this is your reference for changes in your systolic pressure and pulse pressure. So the systolic pressure max is up here, and that's relative to the baseline. Your systolic pressure minimum is actually down here relative to the baseline. Again, it's come down throughout a single ventilatory breath. And this difference here is called your D up or delta up. And similarly, this is called your D down or delta down, this difference here. And what I've indicated here is kind of a generic airway pressure tracing, and then you can see that really by the end of inspiration is typically when you have your maximum systolic pressure, and that your minimum systolic pressure is occurring during expiration. And you can probably already guess, or maybe you already know, that the reason that the drop in systolic pressure is occurring during expiration is because this is the pulmonary transit time. So during inspiration you're having that reduction in right ventricular output, and then a few beats later that decreased right ventricular output hits the left ventricle and then is reflected in the arterial pressure tracing during expiration. Okay. In terms of pulse pressure, the pulse pressure, as you know, is the difference between your systolic pressure and your diastolic pressure. So the maximum pulse pressure occurs typically during your systolic pressure maximum, and your pulse pressure minimum occurs during your systolic pressure minimum here. So you can see the difference between here and here is the pulse pressure max, the difference between here and here is your pulse pressure min. Okay, and pulse pressure variation is actually this value plus this value divided by the average of the two multiplied by 100%. Okay, and what I want to emphasize here is that even though I've depicted an airway pressure in conjunction with the change in the arterial pressure tracing, it is not the airway pressure per se that's driving these physiologic changes. Just because these are on the same graph together doesn't mean that one is driving the other. The airway pressure is indirectly driving these physiologic changes, but remember, it's kind of a few steps away. So airway pressure has to increase lung volume. Lung volume will increase based on pulmonary compliance, and then the degree to which the lung volume increases and then pushes out against the chest wall will determine your intrathoracic or pleural pressure change. And again, that's itself going to be dependent on chest wall compliance. So it's the airway pressure change is a few physiologic steps removed from the actual driving force of the systolic pressure variation. So what are the specifics of this physiology? Well, we've talked a little bit about the basics already, but let's talk about some of the mechanisms here. So this is the pressure tracing we saw on the previous slide. This is your apneic baseline that we talked about. This is your D up. This is your maximal systolic pressure, maximal pulse pressure. So what are the mechanisms of D up particularly? Well, there's quite a few. As I mentioned, there can be this direct transmission of intrathoracic pressure. That is, as you give a positive pressure breath, the pressure within the thorax increases, and this is just simply directly transmitted to the aorta, which will be reflected as an increase in your blood pressure. There's also a decreased afterload effect, as we talked about in Chapter 3 and Chapter 4. That is, you increase the intrathoracic pressure, you increase the pleural pericardial pressure around the LV. That increase in the blood pressure on the outside of the LV actually lowers your left ventricular wall stress, which facilitates unloading of the left ventricle. During inspiration, you get improved left ventricular compliance, and that is the result of favorable diastolic interaction. That is, during a positive pressure breath, the preload to the right heart decreases, so right ventricular volumes tends to be diminished, and as you shrink right ventricular volume, you improve the filling characteristics of the left ventricle. And then additionally, increased pulmonary venous return, which occurs in response to the increase in transpulmonary pressure that you get. And that is a function of how much West Zone 3 territory you have in your lungs. So you can sort of think as the volume of the lungs go up during inspiration, the pulmonary capacitance beds, particularly the alveolar capacitance beds, is diminished, and that tends to squeeze blood out of the lungs in favor pulmonary venous blood flow. And the more West Zone 3 you have, the greater this effect will be. And so the reason that I've put it in red is that really this is, out of all of these mechanisms of D-up, or your increase in systolic pressure during inspiration, this is really the only one that has anything to do with volume responsiveness, or volume per se in general. And you know, the increase in pulmonary venous return that you have, because it's a function of West Zone 3 physiology, you can actually see that in overload state. So this could be a mechanism of a false positive, but it may also reflect the previous expiratory increase in pulmonary blood volume, because during expiration, during mechanical expiration, I should say, the right ventricle is actually being preloaded. Remember, during inspiration, the right ventricle shrinks, its preload is reduced. Then during expiration, the right ventricle is actually accepting blood. And then during expiration, the right ventricle is actually charging the pulmonary vascular bed with blood. Also during expiration, the right ventricular afterload tends to decrease. So there's two things going for the right ventricle during expiration. It's being volume loaded, and it's got a lower afterload. So during expiration, it's actually charging the pulmonary vascular bed with blood, and then during inspiration, that blood in the pulmonary vascular bed is then discharged into the left ventricle. So that's a portion of your D-up too. I think one of the more classic papers that describe this physiology was written by Jourdain and colleagues, maybe in 1983 in Circulation, I think, and they kind of describe it as a piston-like effect of the mechanical ventilator sort of squeezing blood into the left ventricle during inspiration, and then during expiration charging the pulmonary vascular bed with blood as the right ventricle loads the lungs. So these are the four key mechanisms of your D-up, or the increase in systolic pressure, or your increase in pulse pressure. And again, just to reiterate, I've said this before, it's not the airway pressure that's directly driving these changes, it's changes in intrathoracic pressure that are driving all of these changes, not the airway pressure per se. Okay, so what about D down? Well, we've talked a bit about D down already. Let's just go over systolic pressure variation one more time. Here's your apneic baseline. This is your systolic pressure min. And the difference between your minimal systolic pressure and the apneic baseline, this determines your D down. And as I mentioned, many argue, in particular Sheldon Magder argued, that the D down is a better physiologic parameter of volume responsiveness, because it's this D down that's really reflecting that diminished RV preload that occurred during inspiration. And the initial papers on systolic pressure variation actually looked at systolic pressure variation and D down, and found that, you know, a D down as little as 5 millimeters of mercury was, I believe this was dog data initially, that a drop in your systolic pressure below an apneic baseline of as little as 5 millimeters of mercury was very sensitive and specific for predicting volume responsiveness. And so the mechanisms of the D down are somewhat kind of the converse of the mechanisms of D up, which we just talked about. So there could be a direct transmission effect. So again, positive pressure breath during inspiration, the intrathoracic pressure is going up, and then Clearly during expiration it's going down, so you'll have just a diminution of your intrathoracic pressure as being part of it. There'll be an increased left ventricular afterload as the intrathoracic pressure is coming down, but that's probably a minor effect in a normal heart. There'll be a diminished left ventricular compliance as the RV is being charged with increased venous return during mechanical expiration. So the right heart will fill and then impair LV filling capacity. And then there's also probably the most important effect is the diminished venous return. So this is the reflection of the impaired inspiratory RV output that occurred 2 to 3 cardiac cycles before inspiration, because that's the pulmonary transit time. So this is the delayed effect. During inspiration, the RV is shrinking, the RV output is going down, and then that's during inspiration. 2 to 3 cardiac cycles later, as that diminished output traverses the pulmonary vascular bed, you then see that reflected in the D down during expiration. Again, for reiteration, the airway pressure is not the primary determinant of these changes. It is intrathoracic pressure that is driving these changes. And in the passive mechanically ventilated patient, the change in intrathoracic pressure is directly related to your tidal volume of the lungs, and that is related to pulmonary compliance. And it is related to the chest wall compliance. So what about states of high right ventricular? And these aren't just, I'm not just making this stuff up. There's actually, in the last couple of years, there's been some neat papers in critical care medicine that have actually looked at patients with pulmonary hypertension and patients with severe pulmonary ARDS with very low presumed pulmonary compliance. This is a paper by, I forget the group now. I want to say it was Monet and colleagues, but I could be wrong. It was looking at a group of patients who had respiratory system compliance of much less than 30, which is a very low respiratory system compliance. They didn't drop an esophageal pressure balloon, so you weren't able to know exactly if the drop in respiratory system compliance was from pulmonary ARDS or extrapulmonary ARDS as classified by Gattinoni and colleagues in the Blue Journal in the late 90s. But I looked at the patients in that study, and almost all of them had ARDS or had a drop in the respiratory system compliance as a result of a direct pneumonia. So they probably did have pulmonary ARDS. So they probably had poor pulmonary compliance. And actually the specificity of pulse pressure variation broke down in that group almost completely. It was almost like flipping a coin. And presumably the mechanism was, and this is because of the high incidence of right heart failure that you see in severe ARDS, that the mechanical inspiration was actually dropping right ventricular forward flow, not as a function of decreased right ventricular preload, but as a function of increased right ventricular afterload, which is what I'm going to demonstrate here. So the reduction in right ventricular output as a response to an inspiratory increase in intrathoracic pressure may represent preload responsiveness, as we saw in part B of this chapter. And here it is here. So you've increased intrathoracic pressure and you've dropped your right ventricular preload and your right ventricular output. And this is a nice representation of the physiology of preload responsiveness. But imagine the patient that I just mentioned, the patient with severe pulmonary compliance or pulmonary arterial hypertension, patients who are going to be sensitive to increases in right ventricular afterload. And you give that patient a positive pressure breath, what might happen? Well, this patient could be volume overloaded, let's say. Their venous return curve is shifted rightward. They're very close to the plateau portion of the right ventricular function curve. So for argument's sake, let's say that this particular patient is volume non-responsive. That is, if I bolus this patient, they would not augment their cardiac output. And you give this patient an 8 cc per kilogram tidal volume. And you have a large decrement in output because of an increase in right ventricular afterload. So look at the difference here. The positive pressure breath will shift the right ventricular cardiac function curve rightward because of the increase in intrathoracic pressure, increase in pleural pressure, but the increase in transpulmonary pressure, that is the increase in the difference between your alveolar pressure and your pleural pressure, goes way up because of the poor pulmonary compliance, and that afterloads the RV. So you have this dramatic shift down into the right of the right ventricle, and now you have this drop in your right ventricular output. 2 to 3 cardiac cycles later, you would have a pronounced D down, and it's not because this patient is operating on the ascending portion of their Starling curve. It's actually because the mechanical breath itself induced an abrupt increase in right ventricular afterload. And again, this is stuff that is a clinical reality. This is not just me pontificating. So this is the arterial pressure waveform in the spontaneously breathing patient. You can kind of see it's somewhat or almost the opposite of what it was in the mechanically ventilated patient. So again, we can define our apneic baseline. This is your systolic pressure at the end of an end expiratory pause, just prior to the onset of inspiration. And you could say this is your airway pressure here. This is your the baseline. So then here, this is your D down, the drop in your systolic pressure that occurs with inspiration. You have a drop in your pulse pressure as well. And then here, this is your maximal systolic pressure. This is your DAP. And again, this is fairly variable, but your increase in your pulse pressure or your maximal systolic pressure, which can occur during a spontaneous expiration, is probably more a function of the increased right ventricular preload and increased right ventricular output that's occurring during inspiration after a short cardiac cycle time, or a short pulmonary transit time of 2 to 3 cardiac cycles. And this is really the physiology of pulsus paradoxus. So everyone has a somewhat normal pulsus, right? It's, a normal drop in your systolic pressure is less than 10 millimeters of mercury, but much more than that can suggest pathology, and that is what is the pulsus paradoxus physiology. So again, here's the waveform in the spontaneously breathing patient. This is the apneic baseline. This is your D down. So what are the mechanisms of the D down in patients who are spontaneously breathing, and how could this degrade the specificity in a spontaneously breathing patient? Well, like we talked about in the previous section, during inspiration, there's a drop in your intrathoracic pressure, so there may be a direct transmission of that, so that could be part of the problem, part of the physiology of the D down during spontaneous inspiration. There could be an increased left ventricular afterload. Again, that tends to be a minimal effect in patients with normal cardiac function. The key mechanism here and the physiology of the quote-unquote normal pulsus is diminished left ventricular compliance, and that just occurs as the right ventricle is charged with blood. On inspiration, the compliance of the LV is impaired. And then also during inspiration, during spontaneous inspiration, there could be decreased pulmonary venous return. This latter number 4, decreased pulmonary venous return, tends to be less of an effect because, as we've mentioned, as you inspire and you increase your transpulmonary pressure, you tend to squeeze blood out of the lungs into the pulmonary veins and towards the left ventricle. But in theory, this could be part of the physiology or augment the physiology in somebody who's profoundly hypovolemic. So the augmentation of D down during spontaneous inspiration. The presence of a right ventricular failure with or without the presence of excessive right ventricular afterload can exacerbate D down or delta down. This is in essence abnormal pulsus paradoxus physiology and clearly does not indicate fluid responsiveness. A good example of such physiology is cor pulmonale. Inspiration will augment venous return by recruiting abdominal venous capacitance, therefore improving the pressure head for driving blood back to the right heart and simultaneously reducing right atrial pressure. So you dramatically increase the gradient for blood return to the right heart. Elevated right ventricular afterload and compression of the left ventricle by hyperinflation of the lungs in cor pulmonale will only magnify this physiology. So let's consider, this is kind of one of the caveats for a D down in a spontaneously breathing patient. One consideration would be the clinical state cor pulmonale. So here they're side-by-side right ventricle and left ventricular cardiac function curves, assuming they've got a normal left ventricular cardiac function curve, but their right ventricle is highly afterloaded, say from hyperinflation, and maybe poorly contractile from years of high afterload. So the decrease in intrathoracic pressure during inspiration tends to distend the RV to an excessive degree. So you can see, because the cardiac function curve is bent down and to the right, it already has a pretty high distending pressure. So if you looked at the right heart on echo here, you might see a distended RV. And then as you inspire, you're actually going to increase that distension, increase the transmural pressure to a much greater extent. And as I mentioned, I'm not illustrating it here, but pulmonary venous return curve will actually shift to the right somewhat as the diaphragm descends and recruits unstressed volume into stress volume, and improves or actually increases mean systemic filling pressure, increases the gradient for venous return. So this physiology will actually be even augmented by that. Nevertheless, in cor pulmonale, with a spontaneous inspiration, the right ventricle will dilate. You may actually have worsening right ventricular afterload as lung function increases. And what that will do is, during inspiration, you'll impair left ventricular compliance, shift the curve down into the right, and drop left ventricular output during inspiration from here to here, as we just saw. So the drop in intrathoracic pressure can elevate left ventricular afterload. And additionally, if the patient is really hyperinflated, kind of like the teardrop heart that you see in the chest x-ray, and they've got lower lobe gas trapping, that can compress the left ventricle and further impair its compliance, and really impair left ventricular function. The augmentation of pulmonary venous flow with increased lung volume tends to retard the magnitude of D down. But again, you can see that clearly in a patient with cor pulmonale with a high inspiratory effort, they could artifactually cause a D down, and that does not mean that this patient is fluid responsive.